I'm off the video again, so I'm not too distracting there. So let's dive in, why don't we? So we'll turn that off and let's get started.
People say, I am the best boss. They go, God, we've never worked in a place like this before. You're hilarious. And you get the best out of us. I think that pretty much sums it up. I found it that Spencer gives.
So good old Michael Scott, being a fictional character that he is, fortunately he's fictional. I find myself watching The Office over and over again, as I'm sure some of you may. And as some of Michael's antics come about, kind of make me ask myself, what is he thinking? How is that supposed to be a good idea? And as I'm sure some of you have experienced watching that show or other shows, or some of you may have experienced in the classroom with some of your students, or taking interns in the field and precepting as somebody's supposed to be finishing out their program, that they make decisions, they take actions, they deliver some type of information that really makes you wonder, what is it you were thinking, right? Why did you choose that? And if you've ever had that experience, well, then you're in great company. You're in the right place, because that's what we're going to talk about today is, what were you thinking, right? Thinking is a skill. We can teach it. We can practice it. But hoping for luck to think well, we're kind of in a high stakes game to just, try it out and not really practice a whole lot. So that's what we're going to discuss today. Here's me. Got a little brief introduction of me. I'm our clinical chief at the Cy-Fair Fire Department. We're just outside of Houston, Texas, in the northwest corner of Harris County. Actually, yesterday was my anniversary here, so that's exciting news. I'm responsible for our quality improvement, our process improvement, kind of refining our clinical guidance that comes from our medical director and guiding our practices. Right? I have nothing to disclose. Any of the products, concepts, ideas that you see in my presentation, these are just the products we use at work when I have some pictures to take. I'll give credit to some of the books that I reference, but nobody's paying me to include their material. I just include it because they're good ideas, and I think they're applicable to what we do. So let's talk about why it's important to discuss thinking, or metacognition, which is thinking about thinking, right? It's more than just this fancy word. It's not just some college idea for academia. It applies to us, that we consistently make a large amount of decisions in a relatively small amount of time. I was reading an article just the other day that said an average human being makes about 2,000 decisions before lunchtime. 2,000 decisions. Yikes. So let's take in that context of ours, like we have those decisions, but even before you leave the station, you're making decisions, getting on your truck, which hand reaches for the door handle, which foot is the first one to step in. Do you do that kind of backside in thing, or do you move into your seat like from the side and then swing your legs? All of these are decisions you make and you haven't even left. Even before that, your station alerting goes off and it's, do I sit here and listen to the call? Do I start walking and listen to the call? We make a lot of these decisions that don't come with a lot of thought. But then we get into the situations where we know we're making decisions on medications, on treatment paths, transport destinations, things along those lines, right? So we've already made these decisions and we get into this bigger realm of larger decisions. And what we need to do for these more challenging decisions is move higher up this taxonomy. So if you've ever been in an NAEMSE instructor course, you've heard of Bloom's taxonomy. If you were fortunate like me to have the instructor course with Dr. Nolette, he danced for you and performed the taxonomy in a way that you will never forget it. So that's an exciting idea too. But we're moving towards the top end of this taxonomy. Just like we want higher thought processes when we teach and we learn, we want to be in this analyze and evaluate and this create range, because that's what we're doing. Right? You're going to hear those words a lot as we move through some of these practices. Yerkes and Dotson, a good 100 years ago, they help us emphasize the point on why training thinking is important at all in the first place. Okay. So they're telling us that there's an inverse relationship between the stress we want to feel in performing a task and the difficulty of the task, right? So if we have a very easy task, something that's mundane, something that's routine, we as human beings, we want that to be challenging circumstances around the task. Let's make it exciting. Otherwise, it's kind of boring where we're here in this green hill. Likewise, we get into the very challenging, difficult skills. We want low stress. We want the circumstances around it to be less demanding so that we can focus on that task. And then, of course, we get in the middle that we have a medium amount of stress with a little bit of challenge, and that's where we tend to perform our best. I like it laid out in this kind of map too, that, right, we want to be in that focused and engaged range. We need to be cognitively engaged, cognitively stimulated enough, and have enough challenge to make us feel like it's worth our effort and time to put us in this focused and engaged range. Now, we've all been to the left of this where the demand for our performance is low. It's a very low skill. And the circumstances around it are incredibly undemanding and unexciting. Doesn't really get you excited if we're over there to the left, okay? Likewise, if we go to the right where the demand is high and the stress is high, the anxiety is way up, right? Those high risk, low frequency procedures in the low frequency populations where the stakes are high, that puts us over here off to the right end. That starts producing physiological responses. That starts interfering with our cognitive processes. Right? When we get to this range, we're going to fall back to what's comfortable. That's how we cope as human beings. We start stepping back away from the uncomfortable stuff towards what's comfortable. So if what's comfortable for us then becomes the lower ends of the taxonomy, where we're starting to go for pattern recognition based on memorization, that if pain equals medicine kind of thing, and not really creating solutions and analyzing the information in front of us to make clinically sound judgment calls. Okay. When we get over here to the right, this is from David Grossman in a book called On Combat. Does a lot with performance, a lot of psychology, really good read, very sciencey, kind of brainy stuff, but it applies to us. So this graph is directly from him, and this is him talking about this bottom right corner of our curve where we are under high stress with high demand to perform. Our heart rate comes up. These are the physiological responses I'm talking about, okay? I refer to this as panic physiology. It's your fight or flight response. Heart rate goes up. We get these derangements in our sensations then, right? If you take a look, 90 beats a minute, we start to lose our fine motor skills. Fine motor skills. We're already wearing gloves, other PPE. We all know that medicine's a business, so who knows what IV catheter you're dealing with this week, because it's the cheapest one that we could buy versus the one we had last week. It may not be the consistent one. That's just how it goes. So at 90 beats a minute, that's not a lot. That's really not a lot, right? So as we get under stress, we start putting a physical demand to it of moving a patient, moving equipment. We rapidly climb this heart rate chart and we start losing more of our sensory capabilities, okay? Our ability to get creative starts coming offline. The tunnel vision sets in 100%. It's a part of your fight or flight physiology, so you're not distracted by other stuff around you and you can focus on the threat in front of you. Auditory exclusion is absolutely real. I don't know how many times, and I'm sure many of you also have either experienced it or you've had discussions about interactions after the fact with your crew, and it's, oh, I didn't even hear you say that. Are you sure you said these things? When did that, right? Auditory exclusion is real. And some of the physiological explanation is that we have vasodilation as part of that fight or flight response, and the vessels in your ear dilate. Much more blood moving through a lot faster under more pressure, and that turbulence kind of creates internal white noise that the auditory input from outside your ears can't overcome. So we start missing auditory cues and information and chatting back and forth. If we don't take some steps to manage that, we start going further to the right. This is when we become unproductive. We start having this, we need to flee, we need to freeze, lock up, right? we get to that full-on, full-blown panic response. So the reason we need to do this is the further we go up this chart, we start losing our ability to solve problems. We start losing our ability to be empathetic to our patients, to the family, and we lose our emotional control. So if we lose our emotional control in a stressful environment, we're supposed to be the calm. But if I start getting short-tempered and snippy because I'm feeling kind of scared about this and I don't feel like I'm in control, then I'm going to snip at you. And then you're going to get snippy back with me. And then we're going to get snippy with the family. We're going to get snippy with the patient. And all of this then becomes focused on hurt feelings and fear, not on actually delivering empathetic clinical interactions, okay? So again, when we're under stress, we step back to what's comfortable. That's what we cope with. So if what's comfortable, if what we're familiar doing with what we've practiced is just memorizing things out of a book and being able to recall some words, that's where we're going to default under stress. That does not allow us the opportunity to adapt to circumstances and to be flexible and be clinicians. That's very technical when you're just remembering something out of a book or remembering a protocol and following a protocol. Okay, very technical. We need to be more clinical thinkers. Okay, we need to handle this stress in a new way by making our new default that we fall back to under stress. And that is analyzing the circumstances in front of us. We need to evaluate our decision paths. Which one's the best one? What's going to produce the result? And here it is, creating solutions. So there's your language right out of the taxonomy, higher level thinking. This is what we're going for, analyzing, evaluating, and creating, okay? There is a Navy SEAL named Stu Smith, and he had a quote. It was on it was on a game show, is what it was. But it really stuck to me that he talked about his Navy SEAL training and how it had prepared him. And the comment he made was something to the effect of, you need to get comfortable being uncomfortable. And that really stuck with me a lot. Get comfortable being uncomfortable. So the more times you can challenge yourself to be a little bit outside your comfort zone, the comfort zone expands. That's where growth happens, is outside the comfort zone, okay? That's what we need to practice doing. So let's talk about some techniques to do that. This here's the OODA loop. I wouldn't be surprised if a good number of you have heard of the OODA loop. John Boyd was a fighter pilot in World War II, and he needed a mechanism to train new fighter pilots how to make quick decisions in air-to-air combat. I mean, this is dogfighting, where planes are actually fighting and shooting against planes. No radar, no electronics coming at them, right? Just pretty simple stuff, pretty basic low-tech stuff. Low-tech for flying through the air. So he comes up with the OODA loop here. And I've taken it and I've kind of adapted it to our decision-making processes in medicine, okay? So let's take a little walk through. Feel free to screenshot this. I will even send this to you later. Any of the stuff that I have in this presentation, you ask for later, I'm happy to share this with you, okay? I don't have patents on any of this stuff. I'm not getting rich doing this. If any of us got in this job to get rich, let me know how you did it, because it's not really what we do, okay? We start up here with observe. You take in information. That's all it is. You're taking in the information, the environment, the situation, the patient assessment and findings, right? All of it. We're just taking it in, take it all in. We kind of synthesize it while we're observing it also. So kind of observe and orient kind of blend together a lot of times, because we're in this fast operational tempo where we don't have the opportunity to just very linearly move through. So sometimes we observe and we orient together. And that's putting it into context. I love the word context, okay? We take it, we compare it to previous knowledge that we have, we compare it to the reference ranges we've studied, which, again, here's context in my soapbox about reference ranges. I'm a Chicago kid that grew up in the 90s, so Michael Jordan is the GOAT, not LeBron, not open for discussion. Michael Jordan's resting heart rate when he was playing ball was like 33 or 34. That's his normal. So normal reference ranges from the book, sure, good to know, probably going to be on a test. Also take into account that patient's reference ranges, okay? So Michael Jordan with a heart rate of 40, I'm not considering this a very bradycardic patient because of his normal. I'm orienting to his normal, okay? And then the differentials. Take your differentials, what conditions you think you're dealing with, you move through, what findings push you one way or the other. We orient to that. We lay out a plan. What's it all mean to us? We move to decide. This is picking a path. And when I say picking a path, it's not just picking a couple steps of action, it's that desired end state. I love to ask, what were you trying to accomplish? What was the goal? Because if you just start doing things without an idea of what you're trying to accomplish, how do you know if you ever accomplished it, right? You don't, right? You do some things, it produces a response, and then you decide, do I like that response or not? That's not goal-oriented medicine, and we need to be more clinical than that, which we can be very easily. And that's what happens in decide. We choose which pathway we're going on, and then we act. We execute on the plan. We do it. Here's the kicker. As you notice, this is a circle. It's a cycle. We're not done. We observe again. We take the results of our action, we observe them, take in the findings, we reassess, we orient to what does that mean, right? It may mean that your intervention was effective at producing the desired result. That's fantastic. Are there other observations that need attention now? We did make another decision for another response, and then we act. The decide part can also include the choice to withhold action, right? We get in, we observe findings, we orient to it, we decide inaction is the best approach right now. Performing interventions brings too much risk, too much complication, without much benefit from it. My act is to withhold. Withholding care should be a deliberate thing if it's appropriate for the patient, okay? So this is our tool here, that it gives you good practice, it's adaptive, it's generally applicable. And I like to break this out when I do case reviews with my crews. I had a crew that came in because we needed to talk about their bradycardic patient. They responded to this patient who was poor skin parameters, heart rate was in the 30s, the heart rhythm was a wide complex, altered mental status was garbage, and this crew said, holy cow, this heart rate's a real problem, we need to address it. They started to pace this patient. So they observed these findings, they put it into their context of this heart rate's too low compared to the skin parameters, and we can't even get a blood pressure, and the mental status, perfusion's not what it needs to be. Let's make a decision, we're gonna pace, and we act on it, right? So they act on it, but they don't get capture. So they turn up the electricity, they keep going, That's what they're observing, is it's not producing the capture they're hoping. They go, they max out on electricity and nothing. So they figure something's not right. Let's start again. They turn off the pacer, they make sure the pad's in the right place, they turn it right back on, right? They're oriented to the fact that their observations of their treatment being ineffective, they're seeing that. And then they decide to do it again, they act. And they look forward, it still doesn't work. They do a few more troubleshooting things. Where they missed this was the orientation of it, okay? Of taking in previous knowledge, taking in patient history, and all of these things that if you max out your electricity on the transcutaneous pacer and get no response, typically the answer is not more electricity. There's something else that we haven't observed and oriented to. And for this crew, they missed the renal history on this patient. It was a hyperkalemic patient. So because of the potassium derangements, the heart wasn't going to depolarize any faster, no matter how much electricity we sent to it, right? So there's the observation of this low heart rate and poor perfusion, but the orientation is the context. Why is it low? Why is it low? What information is the patient giving us to explain this as we move into our decisions? As we go through this, I'm going to keep glancing at the chat box and the question and answer as I kind of shift from subject to subject. So if you have questions, throw them in there and we'll talk about it while we're still on that item, okay? So let's talk about problem definitions. This is bizarre because it kind of seems, this one's brainy. This one's pretty brainy, right? This is another practice you can use to make some oriented clinical decisions, actually identifying what you're going for. This empowers us as providers to expand our sphere of influence, and it primes us for intentional and deliberate clinical actions. Okay? Properly identifying the problem, it just unifies all us in the reason for doing the work. So from a very high level view, what we're doing is defining this problem in terms of excess or deficit. Excess or deficit, okay? So what I mean is that I can say I'm tired, and that's a problem, right? I'm tired. We could describe that as an excess of fatigue, too much fatigue, too little rest, too little time in bed, right? Using too much or too little is how we describe excess or deficit, right? If we talk about left-sided heart failure and the left ventricle is not pumping, we can talk about it being a deficit, being too little ejection fraction. If we have hemorrhagic shock, we have too little circulating volume. When we define things that way in terms of excess or deficit, it kind of starts pushing us towards the problem we need to solve. Okay, we go towards the problem. So again, hemorrhagic shock is too little circulating volume. We need to add circulating volume. And then we get creative on how that goes, right? So we just started our whole blood program earlier this week here, and actually had a good traumatic incident on our first day administering our blood. I came from a previous agency where we had whole blood in the field, and 2 other crystalloid solutions for IV administration. So it puts us in this place to be creative of which of these is best, right? So if it's too little circulating volume because it's come out, do I need to stop it from coming out? And then do I need to put it back in? And what is the best choice of putting back in? Sure, for hemorrhagic shock, whole blood is the best solution. But let's talk about sepsis, right? There's too little blood pressure in sepsis. There's too little circulating volume. We start asking why and drilling down, and we find out whole blood's not a great choice for sepsis. We know that, but why not? Because it's not too little blood products in the bloodstream, it's too little liquid staying in the vasculature, right? We can even get into sepsis more and talk about there's too little basal tone, there's too much heart rate, there's too much tachypnea, there's too much carbon dioxide, you name it. When we take problems and we group them together, it's legitimately called a mess. Academic term, it's a mess. Sepsis, septic shock, phenomenal example of a mess. Yikes, those people have so much work that they need done, right? Like I mentioned, too much fever that interferes with a lot of physiological processes, too little volume staying in the vasculature, too much vasodilation or too little basal tone, too much vasopermeability. You can define problems, and there's some you might not be able to do anything about. Too much pathogenic material, too much bacteria. There's some agencies carrying antibiotics in the field that can treat sepsis, and that's great. Now you have a treatment choice for that problem. Me personally, where I am, we don't have antibiotics for sepsis. So if I define the problem as too much pathogenic material, I kind of put that one on the shelf. I can't do much with it, but I can with too much volume, too much fever. I'm sorry, too little volume or too much fever. I can treat those. So when you define the problem, make sure you drill it down and start asking why, right? Sepsis has too much heart rate. Why? Because there's too little volume moving around. Why is there too little volume around? Because there's too much vasodilation. Why is there too much on and on. Treat it like a 3-year-old and start asking why until you get to that point. And when you can't ask why anymore, there's a very good chance you're at your root of your problem, okay? So problem definitions are, again, they're very brainy, but our proper definition directs us towards the problem that needs, towards the solution, what we need. But we don't want to put solutions in. That kind of puts us in a fixation error and it hamstrings us, right? So we're talking about pain management. We don't want to say there's too little fentanyl to manage the pain, because that kind of indicates and it prompts in our mind that fentanyl is the only choice. More fentanyl, more fentanyl, more fentanyl. When maybe that's not the best choice. Instead, we say there's too much pain or there's too little effect from the medication, right? Same thing with there's too little mean arterial pressure. There's too little IV fluid to maintain mean arterial pressure, because then we're stuck with it's got to be IV fluid. But if we come over and say there's too little mean arterial pressure, then we start thinking about how do I increase the mean arterial pressure? Is it fluids? Is it pressors? right? And it gets us into that creative problem solving mindset. So let's talk more about differentials, because I love differentials and I love playing games. So I make a game out of this. Here's how this game goes. Like I said, I'm happy to send this to you. I got it laid out in an outline with a couple different cases. I give you a chief complaint. That's it, abdominal pain. And then you're going to take a moment, you're going to think about abdominal pain, and you're going to pick the top 5 things that you're worried about. Those 5 differential diagnostics that you're going to go through. And I'll give you the guidance even, because, right, again, system improvement here, quality improvement. I always look at the system. So how does the system set you up to be successful? So if you as the student, I say pick out 5 differentials, and you pick out 5, and that's it, you may be missing some of the point of what I want you to take to the field. And what I want you to take to the field is these top 5 things should be what's going to kill somebody the fastest. Okay. I think to any of us in this room or in this virtual room, we'd kind of take that as common sense, but don't overlook that when you have some 19-year-old come into your room and the instructions they hear are pick out 5 things that could cause abdominal pain. They'll pick out 5 things. They might be great with it, but they're missing that opportunity to start critically evaluating what they think could be going on and ranking it. So when you have to rank something and assign value to it, holy cow, that is high level thinking. Okay. So you take these top 5 concerns, you prioritize them. Then you get to pick out 2 findings. Each vital sign is its own individual finding. Heart rate is separate than respiratory rate, separate than blood sugar, separate than skin parameters. I also throw in the patient's history, their medications and allergies, 3 separate options. You don't get to say, give me meds, history, allergies, and a set of vitals. No, that defeats the purpose. You can pull a 12 lead. If you're doing point of care ultrasound, you can say, give me the ultrasound. Only 2. And the guidance there is that you pick out 2 of these findings that hit as many of these 5 differentials as possible, because you're going to redefine, or you're going to reorganize your list. You're going to reprioritize where your concern goes based on these 2 findings. Okay. So you give me 2 findings. I give you those numbers. You go, oh man, that's all I get. Okay. You reprioritize those 5. Maybe the list doesn't change. Maybe you say, yep, I'm on the right track. Cool. Good for you. You do it again. You get 2 more. Then you give me your top 3 differentials that you're going to use to start making your treatment plan. Okay. And what are your first steps in that treatment plan? Then what are you going to do? Okay. We work in this very fast-paced, high operational tempo in our operating space, and we can't really wait to have 100% of the information to be making decisions. And I'm not saying guess, and I'm not saying go off half-cocked or shoot from the hip. No way, okay? Not what I'm saying. But what I'm saying is that we need to get to a point where we have enough information and we've thought about it critically enough that we have enough confidence to start moving in the direction. When I was in the Marine Corps and we were taught these kind of practices, our thing was the 70% rule, that if you have 70% of the information to be 70% confident in your decision, 70% of the time you're going to be in good shape. Okay. So again, I'm not saying be premature. This is just an exercise. You're not even delivering treatment. This isn't in front of a mannequin or anything. This is sitting in the classroom. What I actually like to do is write your 5 differentials on an index card and give you magnets, and you go put them on the whiteboard in the front of the room. I'm going to put you on your feet in front of the room and you physically reorganize and reprioritize. Because that's my other thought too. Again, I'm a huge behavioral nerd, studied psychology, and then brought it to EMS. State-dependent learning tells us that similarities in our circumstances when we learn will help us recall the information later under stress, right? So state-dependent learning is really interesting if you want to read some nerdy stuff. So again, I'm going to put you on your feet because that's the position you're going to be in to think and utilize these skills. So you give me these 3 most concerning causes. Tell me how you're going to initiate your treatment plan, and then tell me what your next steps are after that. What do you need to know after that? Right? I love it because the thing is, what's amazing and what's challenging for us as instructors, right? I've been fortunate enough to be a classroom instructor, and now I'm fortunate enough that I'm instructing our personnel that are in the field. They're active providers. They're already certified. The classroom challenge is that, yes, you need to teach a definitive answer because there will be a definitive answer on a test, right? So I want to readily acknowledge that. I'm not saying dismiss that because you do need your students to pass a test. But if I break this out in my classroom, and actually I'm breaking it out next week as we take another group of paramedics and give them clinical leadership training to be in charge of their ambulance. When you pick your 2 diagnostic findings, I'm going to ask you why. What are you hoping those numbers are going to be? What are you expecting those numbers to be? Right? Were they what you thought? What do you think now? Right? I love it. I love asking why, and it doesn't have to be an answer. Every one of us in this room could pick up a different combination of 2 diagnostic findings, but be moving through this. It's a process to practice. It's not a script to follow. Clinical medicine's not a script. And I think that's where we struggle as educators, is that it's easy to teach a script. Really easy. It's not easy to teach people to have these processes to think, to get to their end game. So here's what it looks like, right? Can't catch my breath. That's what I tell you. You pick out 5 differentials. Oh man, somebody short of breath. Here's the top 5 things I'm worried about. You don't get to see this, but I see this. And you say, I want respiratory rate and temperature, right? I can get deep and be like, well, why do you want those 2, right? Again, pick out 2 findings that are going to hit as many of the 5 as you can. In the purpose, right? Obviously, we're going to get a full assessment on this patient if we're in the field. That's not the point of can you get a full assessment. The point is, I want you to be in this growth mindset where it's not, I can't do it because I don't have enough information. The heck you cannot. Yes, you can. Okay? Take these 2 pieces of information, critically evaluate them, use them to make decisions that are limited in your information to guide your next step. Okay? So ultimately we come through, this person's got a PE. Like I said, it's one of them in the outline that I use that a couple of you are already asking for, and I would love to send it to you. Right? It's not so much about arriving at the end point, but it's the, what are you picking and why? It's the process, not the outcome. Right? That's why I love being in my position, is it focuses on process improvement, not outcome improvement. We need to worry about outcomes, but we're process improvement people. Okay? Process improvement. Because we can't control the outcome. We only have some influence on the outcome, but the process, that's where we get our bang for our buck. So let's talk about that. I love pulling cases. I make all of our new candidates, you come sit with the clinical chief and you discuss one of your cases, because I love having these discussions, right? We kind of get them in the mindset, especially when we hire young people. Young people will recite from the book, and here's what the book says, and here's what it was on the test, and it's fantastic. Those people need that base knowledge that they can recall, they can remember, they can pull from their memory, because they need that to orient to the findings that they're seeing. But we need to coach them above that level, training their thinking. Why did you do that? Why did you think that? What did you expect to happen? Did it happen like you expected, or did it not? Right? That's my favorite question. Little 3-year-old right here. Why? Why? All day long. And the best part is, you don't have to have an answer in your mind when you ask why. All right. My favorite, pain management. We have about 4 different types of, 6 different options for pain management here in my agency. I just ran our annual numbers because I'm our data person too, and we use fentanyl about 10 times more than any of the other options. And it's a fun question, why? Right? It could be that this provider is not as familiar with ketamine, or they had a one-off bad experience giving a patient ketamine. We have a hospital that some of the nursing staff gets a little nervous when we bring them patients that have their pain managed with 20 milligrams of ketamine. So it's a bad social interaction at the receiving destination. Who knows, right? We have IV Tylenol, and it's, hey, how come you didn't do IV Tylenol? And it's, I didn't even think of that, right? I don't have an answer on why or why not, but I want you to know why or why not, right? We don't do things just because, we do things to produce an effect, and asking why makes a big difference. I break out the OODA loop. Legitimately, I have it laminated on a piece of paper, and I pull out a dry erase marker and we start writing on the OODA loop. What was the context? What was the decision plan? I drive home to make these differentials before you start treating. Know what you're starting to go after, right? Know your desired end state. If you tell me just go west, there's a whole lot of west. I'm in Texas, I'm in Houston, there's still a whole lot of west. Heck, I can drive for 750 miles and still be in the dang state of Texas because that's how big it is. It was not, been here 4 years and I'm still trying to wrap my head around that one. I drove for 8.5 hours north, still in the state of Texas. Amazing. Anyway, I digress. But if you tell me just drive west, awful lot of west. But if you tell me drive to San Antonio, I know when I've accomplished the goal you gave me. Okay? We need to know where we're going, why we're going, how we're accomplishing it. And there we go. You ask anybody that's been around me for more than a week, this is it. What were you trying to accomplish with that? I did X, Y, and Z. Okay. I'm going to give you the benefit, especially my QI reviews, I'll give you the benefit of the doubt. You were doing things in the best interest of the patient, and you were doing things to make the situation better. So what were the specific circumstances that you were trying to accomplish with that decision? Help me understand that. Because if I have to verbalize to you why I did something, I have to understand it, right? And that's one of the things in EMS, we kind of get with the patient, we deliver therapy, we drop them off in the hospital, we high-five each other. Sometimes we get feedback from the nursing staff. But there's not a lot of times, especially younger, I know I didn't when I was younger anyway, I didn't go out and think, why did I make these decisions? Were those decisions effective in the way I wanted them to be? They're not, right? I don't think that. Especially when ego kicks in there and it's, oh yeah, things went great, high five. No, those are the best times to pick out why you did the things you did, what prompted that action to produce a favorable outcome, so you can reproduce those. This isn't all about let's correct errors and remedy discrepancies. No, no, no. Take the good circumstances and focus on those too, and how do we replicate them? And we replicate them by what were you trying to accomplish? What was the pathway to accomplish that? Did you accomplish it? Okay. So how do we start with this? How do we take our industry to this next level? We find opportunities to practice. All of us. Not finding practice, we find opportunities for our students, yes, but all of us. One of my pet peeves was getting with my partner and I say, hey, where do you want to eat lunch today? Oh, I don't know. I'm like, come on, man. Like, this is an easy decision. What do you want to eat? Well, I could, like, no preference, nothing. What's that, like, one place in the back of your mind that you're like, oh, my wife doesn't like going there. So if anybody else is like, we're going to go out to eat, this is the place and that's where we're going. You don't have one of those. Simple little challenges. We make, like I said, we make thousands of decisions before lunchtime, right? Think about those decisions and challenge yourself with them. Know that people are watching you. You're in this webinar today. You're affiliated with NAEMSE to begin with because you're one of those people, okay? You're one of those people worth watching. You're one of those people worth emulating. That's why you're here, because you care about the industry, the organization, the people around you. You want to be somebody that people around you emulate. So just keep that in mind, right? Evaluate your thinking, challenge your thinking, because you can always get better at thinking. It's a practicable, perishable skill. Let other people see you challenge your own thinking, especially the young ones. You go on some really critical call and things went okay. You get this candidate in the field, heck, they've been on for a year and they get their first cardiac arrest and things go okay. Challenge the way you think in that. Let them see you challenge your own thinking. Challenge them. One of my favorite questions that'll make you think about it and evaluate it, high-level thinking. Did you like that? Because you always, right? You always ask somebody, what would you do better? It went fine. Cool. What did you not like? I didn't like X, Y, and Z. There's your improvement. What did you like? I liked A, B, and C. Great. How do we make A, B, and C happen again? When you ask people what they like and don't like, what they're really telling you is what they think went well and did not go well. Because we like things that go well. We need to shift this focus. Like I talked about, not the outcome, but the process. We can only control what we put in 100%. Okay, we respond to circumstances and we put our inputs into the process and we influence the outcome in the product. Hopefully it goes well. Fingers crossed. Hopefully it does. Not always, right? We've all had those cases where things just fall apart. Can't get the IV to save your life, equipment falling out of stuff, you and your partner are speaking different languages, all goes to crap. And then somehow you deliver this patient in the hospital, they're decent, they survive, they walk out, they're neurologically intact, and you're like, whoo, dodged a bullet on that one, huh? We all have those cases where things just don't go right, where the universe is conspiring against you. Our process was poor, but the outcome was good. Thank goodness, okay? By the grace of God, this patient has a good outcome. But likewise, we've all had those cases where everything goes right. IVs drop easy, multiple IVs drop easy, airway drops easy, ventilation goes easy. You and your partner are mind melding and words like don't even have to come out of your mouth before the message is at the other end. And your extra crew that's there, like everybody is on their game. You get to the hospital and the specialty team's there to receive this patient and they move over and they listen to this report and they say, you know what, these are good steps. Let's take those steps and continue those, and care goes well. And then this patient doesn't survive that, or has a poor neurological outcome and lives their life in a vegetative state. And we beat ourselves up about it. We can't control the outcome. Sometimes there's circumstances beyond what we can't control. What we control is the process, how we talk to each other, how we evaluate the information in front of us, how we make clinical decisions from it, and how we create solutions. Those are practicable skills, okay? I want to take a moment to talk semantics, because choosing your words is a crucial thing. It's called a growth mindset. There's fixed mindset, there's growth mindset. And this chart hangs in my office. It actually came from the in-charge paramedic from the hyperkalemic case that I mentioned earlier, where they tried to pace this patient and they couldn't. And in that discussion, he bought me this chart. He bought this to me, he framed it. He said, hey, I want you to have this, because that conversation, he is definitely one of these I want to be better people. He would fit in with this crowd. Honestly, he might even be in the room. If you are, Jay, good to have you. He's a really good friend of mine. And he brought me this chart. He said, I want you to have this because we had that discussion that made a really big impression on me. And I remember you saying at least 3 of these things in that conversation. And it helped me grow and move on and think about that, okay? The words you use are powerful. It primes your mind for certain thinking. And again, all eyes are on you. Whether you want to be watched or not, you're being watched. Somebody younger than you, newer than you, less confident, less experienced than you, they're looking at you. And they're going to emulate your behavior because whatever you put out, they have already decided in their mind is that's the acceptable standard. So be aware of that, right? When we start looking to cut corners because it's been a long day, when we say, whenever the crew tomorrow can take care of it, right? We're making those impressions. We also do it with our words, right? If we go with the, what am I missing, right? Don't go with, can I make this better? Yes or no? No, 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 no. How do I make this better? How? Go with how, not can I, how, right? It's amazing. And this has really helped me, honestly, those of you higher up in the organization, this has really helped me in administration. When I have to go to my assistant chief and it's, I need this, whatever. And he says, no, we can't for whatever reason. Budget, personnel, people not interested, don't think you can pull that off, right? I don't go with, can I do this? I go with, hey, chief, how can I do this? What do you need from me to make this happen? That's that adaptive growth mindset. You start using these words and it's focused on the solution. I'm sorry, it's focused on the process to produce the solution, right? As soon as you say, this is too hard, not going to get this, you're shut down. You're losing, okay? Use good words. Your word choice matters. The people around you are going to pick up on that big time. So I love this chart. It's actually sitting right over my right shoulder, and I just took a look at it to admire it because it's huge. I love it. So we're back to the taxonomy. These are the same words we've been using all along, right? We're going to remember and understand and apply some of the knowledge. That's what the students coming out of this classroom are really good at doing, right? And this is not a knock at any domain of education, whether it be in the field, continuing education, precepting kind of stuff, or classroom didactic education. I am not passing any kind of judgment on one better than the other. So if you hear that, let me correct it right now. No way. I actually really love being in the classroom and being the first one to introduce material to people, but I also really like having brand new paramedics in the field and getting to be their introduction on how to put this information into action with another human. Anyway, I love it. I love this job, guys. This is amazing. So we take the lower end of this that the school really drives home. Class programs start driving into this, analyze and evaluate, right? But we need experience to really make that happen. And we can practice as much as we can, but that's where experience is good, because I have more context, I have more prior knowledge and prior exposure to events to synthesize my observations, and I can evaluate against a larger scale of information. We need to practice taking that stuff, creating solutions, and moving wrong way. There we go. And moving ourselves up the taxonomy. We not only need to learn at a higher level, we need to think and problem solve and interact at a higher level, okay? When we start talking about creating solutions, when you identify your endpoint, all the solutions in between are just the world's an oyster, right? I was one of those kids that when I had a maze, I would start from the back because it's so much easier starting from the back and working up, right? You go from the front on and you start hitting dead ends, you hit whatever, you got to start over again. So start from the end. Where do you want to be? And then what's the best way to get there, right? My favorite one is pain management. Pain management all day long. If your goal is to give 100 micrograms of fentanyl as pain management, then you give a dose of fentanyl and you're done. You've accomplished your goal. But a more clinical approach to this is that my goal is to manage pain. And I'm going to define that as taking this 9 out of 10 pain down to a 5 out of 10. So maybe that happens in 25 micrograms of fentanyl. Maybe that happens in 150 micrograms of fentanyl, right? If I get a crew, they give 100 of fentanyl, their patient's still in pain. I said, did you manage the pain? Sure I did, we gave fentanyl. Their goal was to give the medication. I challenge all of you, I challenge them to think in that circumstance, your end goal is to manage the pain and then think about it. A couple doses of fentanyl don't do it. Maybe it's another medication. Maybe there's some splinting that needs to go with this that we missed. Maybe some ice needs to go on this. Maybe it's one of these burn patients, we're just not going to get the pain under control, okay? When we identify the endpoint and not the one route to take, we've got all the solutions in the world. So let's bring this home. Like I told you, 90s kid in Chicago, Michael Jordan had a jump shot. He didn't have a game day jump shot and a practice jump shot. It's not how that works. No, the man had a jump shot. The man had a dunk. He didn't have practice dunks, game day dunks. Okay, maybe he had some game day dunks. The dude had skills. Jump shot was the same all around, okay? Take these things and practice them like you're gonna use them, right? You can just kind of roll through and go through the motions and make a nice show of it. You can do that. But I think that's what you're here for is how do we take that next level? So do that, right? We always talk about practice like you play, and perfect practice makes perfect. You name it, right? We need to take this practice and lay it over our operating space just the way we need to, because we exist in this high stress, high stakes, this time competitive operating space where we can't bank on success being by chance. It's not a coincidence that we're successful. We need to create the opportunity for success, okay? Doing anything else is just kind of crossing your fingers and really hoping that it goes that way for you, right? So think of the endpoint, helps you develop the process, and practice like a professional. Practice like a professional, okay? These are the books that I mentioned. Boyd here has the OODA loop on combat, talks about the panic physiology. That's me up there. If you scan the QR code, it'll give you my contact information. Happy to hear from you. I'm going to grab some of you out of the chat box here. I know a handful of people are asking. Feel free to send me an email also. Just have you in the address book. Stay in touch with things, chat about ideas, thoughts that you got, especially as this marinates overnight next week. You go put something in action and it doesn't go the way you wanted, let me know about that. I would love it. So I'm going to step back a minute. That's all the material I have, and I will take a look at the question and answer box in the chat box. Feel free to give me any of your thoughts or your questions that you have in there.
I didn't see any questions come up in the chat, but there are certainly a lot of compliments and agreements.
Mostly with Michael Jordan being the GOAT, which is fact, by the way. So Kathleen here, which is my wife's name, so you're already like moving up in my book, like Kathleen. She's talking about doing research with virtual reality simulation and using it for critical thinking. And me personally, I tried. There's a lot of good companies out that have, I don't even know what you call it, because you know, not to be like too boomer-esque and old, I don't know what like the virtual world is called, but there's companies that create those virtual settings that you go get in with the virtual reality masks and can do these clinical practice things. They're incredibly expensive, is why I never really got to do much with it. It's cost prohibitive from where I was. But if anybody has some experience with doing research in virtual reality simulation, challenging thinking, those kind of things, feel free to throw it in the chat box, because we got somebody attending here that's looking to do stuff like that. And I think that's a fantastic opportunity to collaborate. So I'm going to hang out for the next 7 minutes because that's what I got scheduled, but I'll stop talking, but I'll be here. If y'all have questions, I'd love to hear from you. Send them in there. Otherwise, I really appreciate your attendance. I appreciate your time, and especially all of these comments coming in there. That would be great.
Yeah, thank you so much, everybody. Like Kevin said, we'll keep this open until 3 Eastern time. I put the link to register for your CEU in the chat box, but if you missed that, it'll be in tomorrow's follow-up email. And I will also make sure that I get all of Kevin's fantastic resources, and I can put those up on our website, and those will be included in the link in your email tomorrow as well.
Sherry, I think what you're referring to is state-dependent learning. Was what I had mentioned, where we want similar circumstances in learning as we do as performing. Yeah, tons of literature on that. Wendy, we were talking about state-dependent learning. I'll even put it here in the chat box. Mitchell, thanks for that book reference for the one of the nail. I haven't heard of that one. So I'm gonna put that on my list. Thank you. And for those of you who are still hanging out, here's something else that I use. Here's a nice little bonus for you. It's called I Dissent. It's a game. It's Ruth Bader Ginsburg's game. No politics involved with it, right? None of that stuff. But it's amazing because what she does is make a bunch of cards that you argue over, and they're fun, non-polarizing things, but they are kind of polarizing. There's things in there like a hot dog is a sandwich. And then you have to argue your point of a hot dog being a sandwich or not. And again, when you have to take these ideas and you have to defend them, that takes things to a higher level of thinking as well. And it's just fun, right? Hot dog's a sandwich. That's kind of the most notable one. Grape is the best flavor popsicle, which is just a fact. Everybody knows that one. See, Jeremy, we could have a good discussion on it.
Oh, Sherry, that I'll send that again. I think that state dependent learning might have just went to just the hosts here.
Oh, did I not put it in? I'm sorry.
No, you're fine. You're fine. I do that all the time.
There it is.
You should be able to see that, Sherry.
There we go. Thanks, Rio.
Yep.
Thanks, Jeremy. Glad to have you. You're welcome, Mitch. I'm glad you enjoyed it. You guys had such nice things to say. I appreciate it. Thanks for that feedback.
Sherry, I think the only thing that he put in the chat was state dependent learning. Any resources that he talked about today, I will make sure that those links will get sent to you. Sherry, in case you missed it as well, there's the link to register for the CEU. If you need any help with that, I know that you have our emails, so you can email us. But is there any other questions, anyone? Anything else? I'm so glad that so many people have still hung out. I see there's still 27 people in here. That's great.
Right. If we weren't virtual, I'd say we'd need to go get some coffee or other beverages, something.
That
Go
would
hang
be
out.
fun, like a NAEMSE coffee talk.
Yeah. That's something. If we ever meet in person, you want to win me over, coffee's the way. I'm not tough to win over. Sherry, you're local? No kidding. We might have to connect while you're over here. I didn't realize you were so close. I saw some of the early emails come in from Juneau. Getting some Alaska folk. That's awesome. Oh, New York. Okay. Well, stay warm up there. All right, y'all. I'm going to move on to the next part of my day. Like I said, I really appreciate you hanging out, the attention, the comments. You guys are fantastic.
Yeah, thank you so much.
Great day.
That was fantastic. Like I said, I will make sure I get all of the resources, Kevin's contact info. So everybody should have everything. And Kevin, if there's anything else you need from me later, just feel free to email me. And this will be up on YouTube shortly.
Fantastic. Thanks for all your help today, Rio. I appreciate it.
Oh my gosh, yeah, of course. Thank you. That was fantastic. And thank you everybody for joining in. We will see you later. Bye.